Today, Dr. Chris Main. Chris is medical director for Prime Recovery and Wellness, my clinic. He's also a friend of mine, and he has a ton of experience in orthopedic surgery.
That's correct.
As well as hormone therapy.
Yes.
So Chris, tell us a little about yourself, and then I'd also like to hear about your personal experience because you're also on TRT.
That's correct, yeah.
Yeah.
So appreciate you having me here, Matt. Really enjoyed getting to know Matt and his crew over the past couple of months. My background, I'm an orthopedic surgeon. Came into practice way back in 2001, so lots of years of taking care of shoulders and knees, fractures. You know, pretty much I've seen it and done it over those years. So from there, I got into doing some hormone therapy through some friends of mine in St. Louis, and we started putting that into my own practice as well for some patients, and it kind of just took off from there that I really enjoyed that type of work and felt that as I round out my orthopedic career down the road, that was where I was going to head.
Nice. So if you see Chris, you can tell he's not the nerdy doctor, right? He's actually a jock. So you used to do decathlons, and you ran for Nike for a while, right?
I did. I ran for Nike for a year and blew out my back.
Okay.
It's kind of what ended my track and field career, but you know, at one point I was hoping to be one of the next Dan or Daves for the decathlon.
Right on. So if you don't mind me asking, how old are you now?
54.
And when did you start TRT?
I've been on TRT about 6 years now.
Okay. Right on. So Dr. Main does all of our, well, not all, but the majority of overseeing of our nurse practitioners. He's has an interstate compact license, which opens you up to, what, 38 states?
38 states, District of Columbia, even a couple of islands that are U.S. territories as well.
Right on.
Yeah. So
Cool.
It was a awesome thing to get. Finally, I've been working on this thing for months, and with the growth that I want to have, you know, personally for my practice and helping, you know, your practice out, this is something that was necessary in order to get into treating multiple people.
Right on. What's your personal experience with TRT, like before you started to now? Like, how are you feeling? What kind of guy like you expect people are watching? They started TRT.
So, you know, as a former athlete, going through some injuries, you finally get into that, you know, middle age group, in my opinion, when I started noticing things as I came out of residency that you try to spend as much time in the gym as possible, but when you're working crazy hours and then get into practice and trying to build your practice, it's just tough. And I felt fatigued. You know, I certainly got to see some changes in just, you know, mental fog and clarity over the years as I gotten older, and you kind of develop that dad bod. And my kids got old enough that I don't think they could ever still take the old man, but it was one that I wasn't going to give them a chance to. So I felt that, all right, I needed to make a change in my life for, you know, getting a little bit leaner, getting more muscular again, helping just mental thought process, sleep patterns, relationships, things like that. And for me, once I got on it, it was just like a click of the switch within a few weeks of just making me feel better, you know, overall.
Right. Yeah. So Dr. Mann and I both been on TRT quite a while. I would say the majority of the doctors that we're working with so far in the company with Prime, they live the life too. So that's kind of a benefit difference between some of the, you know, you go to a primary care doc, and it's hard for them to relate because not all of them understand testosterone therapy, and especially if they're not on it. So the difference between a primary care doc and what Dr. Main would be prescribing, we're more on the optimization side of things. And you say how you treat a patient and a symptom, not a number, right?
That's right. Yeah, I think number ranges for testosterone, especially for males, there's such a wide range and variability that if you don't treat a patient's symptoms, you're going to miss a lot of, you know, impactful, you know, changes that you can make in somebody's life. And I think it's where the primary care docs, that either they're scared of it, they don't have enough training, or they've never done enough, you know, extra research to figure it out. And they're trying to stay in a range and treat a number instead of what's that patient coming in with.
So what is the range generally, though? Like, where are you seeing things?
So most people are going to come in a normal range of, you know, anywhere between 350 and 700. But depending on the type of patient that we're working with, their age, other health issues that they may have, they might be 500 and feel terrible. They might be 250 and feel terrible. Same symptoms, but yet how they react to what's in their body is going to be completely different. So I think, when someone comes in, we're not trying to make them superhuman by any means, but yet we want to just give them a better lifestyle. And by putting them on therapy after proper evaluation and discussions and looking at labs, that's what we do.
So the whole process is, right, with Prime and how we're working together, it's telemedicine. Dr. Main oversees these nurse practitioners, make sure they're doing their job well, staying in compliance. But the client will either find us through social media or through our website. They'll have an initial consult to get an idea how the process goes. Then we'll either have them in for a blood draw, or we'll send them to LabCorp request and get those results back. The nurse or the doctor then has a inpatient or a Zoom consult, and then they decide what protocol is going to be best. Is it TRT therapy, or do they just need vitamin D, or is it TRT and aromatase inhibitor if your estrogen's high? On the panel, since you've come on, we've adjusted our biomarker panel on the blood draw. It's more elaborate. Talk about some of those markers and why they're important and how they synergistically play a role in optimization, testosterone, and performance.
Sure. So everybody that kind of listens to these type of podcasts, they at least have some basic understanding of, lean muscle mass, muscle growth, things like that, of how testosterone can help them. But there's lots of other things that we look at as markers on that, and especially dependent upon the patient's age group. Sometimes you'll catch people with prostate issues. Sometimes you'll catch people that are diabetic that have been treated for diabetes. And yet if you make some other corrections metabolically, testosterone being one of them, you can see some improvements in how insulin levels are regulated in the body, with cortisol levels as well. You can see changes in blood counts. You can see changes in electrolytes. So we look at just a multitude of labs that if any patient went through their primary care doc and went to go to a lab and put it through their insurance, they're probably paying over $2,000 for that lab. And luckily we've been able to talk with the lab groups and say we want to improve this option to make it more available for patients on a cash pay basis, and they're getting a huge panel now for a fraction of the cost of what that is. We take a look at that panel, look at the specifics, male or female, at certain markers, and then make that treatment plan algorithm from there to initially start them, and then we'll do follow-ups on that just to see what adjustments might need to be made from that point.
Mm-hmm. So on those panels, so we've actually I help the liaison wellness coach. I help get people through the process, get them to blood draw, get them to talk to the doctor. Some will accept blood work if it's within 90 days, right? But the thing is we're getting some of this blood work, and you've seen the standard blood work from your primary care or these guys coming from the VA. It's like nothing. Yeah, there's hardly anything on these panels.
It's so minimal.
It really is. So you we take that, and then some of it we can't even accept because so I know our panel is elaborate, but what are some of the markers that you just absolutely have to have? Otherwise, you're going to require them to do all new blood work.
Well, we look at testosterone basically as a whole. We can also look at free testosterone, but some of the things that are specifically missed would be PSA levels, looking at prostate health, hemoglobin A1Cs, which are diabetic markers, thyroid panels are a lot of things that aren't ordered, which, again, if there's an issue with the thyroid, that can affect how everything starts from really the head and neck area down through the adrenal axis and the gonads of producing testosterone. DHEA levels are something else we look at. Sex-binding hormones, those are things that just play different roles in the body of how testosterone is either produced or how it's actually absorbed and utilized in the body. That those micro adjustments can make a huge difference in someone who comes in with just a very basic lab panel.
Mm-hmm. So with Prime, we're doing telemedicine. So the patient, if they're a candidate for TRT, male or female, then their medicine just comes from the pharmacy or a supplier to their door. You've said in the past that testosterone cypionate is like the gold standard. Why do you compare? So we have the three types of testosterone, what are primarily propionate, cypionate, and enanthate, right? Mm-hmm. Why do you prefer cypionate over any? And let's compare that to pellets too.
Sure.
You know what I mean?
Pellets is an easy one to knock out of the park. So, for guys especially on testosterone, I like the cypionate just because I think the time and how it's absorbed into the body is better as far as bioavailability. It's in your system for basically 7 to 10 days. So if for some reason someone either injects or under injects, within a very short time frame, you can make the adjustments from there. It's very irregular that somebody would do that, but it has happened where they don't pay attention to the instructions that are sent to them. So I think those, as far as how it's absorbed in the body, is probably the best option versus something that's more of a longer acting type of substance that, one, it takes longer to get out of your body and adjust, and then some of them are even shorter acting as well. So I think the gold standard is still going to be the cypionate just for the 7-day absorption.
Right.
As far as pellets, I'm a fan of pellets in female patients in certain instances, but the thing that people have to realize, whenever you go through a pellet company, you're getting basically an algorithm on thousands of patients that's based on numbers still. It's not based necessarily on symptoms. And when they say, well, this is how many milligrams of XYZ in a pellet that we're going to put in you, once that pellet's in, it's not coming out. Okay, you have a higher risk of the pellets being extruded out of the body. You have a higher risk for infection because it is an invasive procedure. And if you have to make adjustments on that, okay, if it's too high, you can't make an adjustment. You have to wait for that to basically dissipate over time. If it's too low, then you have to come back in and put more pellets in. For people that are trying to get lean, those pellets are subcutaneous around the gluteal fold, so those are noticeable if you sit down or have your back against a hard chair. So it's not a comfortable thing, and I've had several people that they just don't want that. However, there are some that do. But I would say that's probably more of our female patients that they just don't want the injections on a regular basis.
Okay, so primarily the benefit to pellets would be convenience and lack of, if you have fear of needles.
That's correct.
Right? Yeah. Whereas I guess if that's the case, you could do a topical, but then you run into issues like, do you have little kids that are going to be crawling on you? Are you going to, transfer that to them? So yeah, it's interesting. We had a guy on the podcast, gosh, it's been a month or so ago, but he's on pellets. And he works out, but not a lot, right? And he's just kind of wants to feel good, wants to have pursue his significant other, have that romantic relationship, spark still there. And he got pellets, and his blood work came back at over 1,600. Mm-hmm. And he's like, whoa, that's more than I wanted. I wanted to be 800, 900. And his doctor just told him, well, you got to write it out. It'll take a few months. And that's where I have a problem with the pellets. It's if you hit the mark and you get it perfect, great. But everybody handles things a little different. You could take 200 milligrams of testosterone and come back at 900. I could take 200 milligrams and come back at 700. Right. So it's not always, they're not a one size fits all for this stuff. So it's more convenience, if anything.
It is. It's a convenience that people don't want to go in and out of clinics, do injections on a weekly basis. They just want to be a one and done type of thing. But again, there you're treating a number. You're not treating symptoms. And that is a complete difference in how I practice this type of medicine. I'm certainly not going to make someone superhuman and try and get them up to above 2,000 on a testosterone level. But yet, if someone feels symptomatic still at 900, we're going to bump them. Okay? If I've got somebody who feels great at 600, we're not going to bump them. It just depends on what that situation is, which you have to take into fact their age, comorbidities, and just what their goals are as well.
Yeah. So if you guys are watching, you may have seen Dr. Mann and I on Andy Elliott's podcast, and the title of that podcast when it dropped was, "Is Andy Elliott on steroids?" So let's go through that a little bit. I know, so what is the difference between testosterone being bioidentical and then steroids? Because steroids is a pretty big umbrella, right? That covers prednisone that you would take for poison ivy, all the way to anabolic steroids that you hear the guys talk about in powerlifting.
Correct.
Yeah. What's your opinion on that? That's a question we've been getting quite a bit.
Sure.
How do they differ?
So testosterone being naturally available in the body, okay, it's not anabolic. Okay, it's not something that we're producing outside the body and then supplementing that. It is a foreign substance to the body that is going to cause rapid muscle growth rather than gradual, which you see with testosterone. It has much more harmful effects in the long term that can affect patients between high blood pressure, testicular hypofunction. You can see all sorts of really bad problems, especially being on anabolics for quite some time. Now, in my own practice, of course, I'm using corticosteroids for injections for knees and shoulders and things like that. We also occasionally use oral prednisone for anti-inflammatory effects or allergic reactions, but that's completely different how those work in relationship to testosterone as more of a safer alternative to the higher risk type of issues with the anabolics. So anybody that we see coming in that is on anabolics, our first thing is, well, if you want to be a patient, we need to get you off of this and get you onto something that's going to be safer for you in the long run.
Mm-hmm. Yeah, I mean, you think about it, they have inhalers that are considered technically steroids. So I think that steroids is almost a buzzword that people they kind of cringe at, and it's not really fair to put these bioidentical hormones like testosterone, progesterone, estrogen under that umbrella, because it gives it the wrong perspective.
It's the wrong stereotypes, what it is.
Yeah.
We want to be able to use safe medications that have been used for quite some time with great reproductive results, rather than things that we already know. There's multiple literature out there that shows that anabolics are bad for you in the long run. Certainly, there are going to be guys in certain areas that they're taking them. Competitive edge for certain types of lifestyles. But again, we've all seen the documentaries and things like that for guys that have been on steroids for quite some time, of how that affects them as they get older.
So tell me a little bit about the side effects that people, so if they got on TRT, what they could expect, what side effects, and then also if they didn't get on TRT, what life looked like in that realm, like the effects of not choosing to stay, keep your hormones where they need to be and letting them fall, because there's definitely some downfalls to being low T.
Sure. So side effects for testosterone itself are actually very minimal because it's such a short half-life in your body. You can see testicular shrinkage is one option that you can see. You can see acne, in the females, we can certainly see changes in voice, but the side effects in those natures are so minimal as compared to the positive effects with it that's why people choose to be on that.
Isn't that dose dependent as well?
It is. Yeah, the higher the dose is, the more chance that you can see some of those type of situations. But again, if it's a male patient, higher dose versus female patient at a lower dose, they're still going to see some potential side effects from that. But again, it's really rare, and it all depends again on what type of situation they're in. I've got a couple power lifters in St. Louis that are females. They're taking 200 milligrams a week. But they're nationally ranked power lifters, though, too.
Sure.
They'd kick my rear end right out of the gym. So, it's completely different than I've got, soccer mom who is, 35, 40 years old that's wanting to lean up a little bit, lose a little weight, that they're on a 5 or 10 milligram dose a week, that they're not going to necessarily see the side effects from that.
Yeah.
The anabolics, you're going to see all types of things. You can see, the rage from that, mental status changes, acne, certainly testicular, shrinkage as well. But those are more significant in how quickly those can occur. And some of that stuff is even more difficult to reverse even once you come off of it.
Yeah, and I've realized too, with my own experience and then some of the patient feedback, it's, it's the range, it is dose dependent, but generally with testosterone, with the guys at least, the side effects seem to be mostly related to estrogen. If you can keep your estrogen in normal range, everything seems to go pretty well. That and like the red blood cell count. So I think TRT is really safe. However, if you're going to be a female powerlifter at 200 milligrams, you're going to be the special ops guys running at 1,500 total test. I think it just comes with a couple more responsibilities, right? And it means you got to monitor your blood pressure, red blood cell count, keep an eye on your estrogen.
Yeah, so we're getting blood work typically at 3 months, after initiation of treatment, 6 months, and then usually a year. At that point, we're hoping that, people are pretty much regulated for the most part. But again, micro adjustments can still be made. If we have people that are coming in, whether it's increased water intake, I feel like they're starting to still gain weight even on testosterone, or testicular shrinkage, then we'll start talking about aromatase inhibitors with an anastrozole, something like that, to help prevent that. And again, we may start them on a half tablet versus a tablet once a week, just based on those symptoms. I think that, again, that's all got to be individualized just based on how they feel, and continue to monitor that. There's been a lot of false studies out there that talk about testosterone, causes heart disease or prostate cancer. Well, those have all been pretty much proven negative. So I think that as long as you're not, again, trying to become superhuman, then that's where that comes into play, that you're just treating the symptoms to feel better, making sure your blood pressure is under good control. And if we have people that have high blood pressure, we're still getting that treated through their primary care providers or cardiologists, and verifying there's no other red flags that pop up that says that they should or should not be on testosterone. So we're not there to medically manage their entire life. We're there to manage their hormones, but we do sometimes work with their specialists as well or their primary care physicians just to make sure if there's something that we need to have a question about, we're all working as a team.
Nice. And, you mentioned the aromatase inhibitor. Mm-hmm. So what that's going to do is help reduce estrogen, correct?
Correct.
Because you need some estrogen, but too much is a bad thing and too little is a bad thing.
Correct.
Too much, you're going to retain water, potential acne, right? Maybe a little bit emotional.
Yes.
And then with not enough, you're going to achy. You're going to have trouble putting on muscle mass if that's your goal. So that's a pretty, I personally, I'm on a half milligram a week, and that's all I need. Some guys don't even need it at all.
Yeah, I don't take it.
Yeah.
Luckily right now, I don't feel like I need to, but, that situation can change. Every
Sure.
every year is a little bit different.
Sure. And I think people associate testosterone with men, estrogen with women, but we have them both. And until I came on with Prime, I was unaware, but females have more testosterone than estrogen in their reproductive years.
That's correct. Yeah. It's a very unknown fact that when you tell somebody that, they kind of look at you with this stark glaze.
Right? Yeah, because hormone therapy is not for just men. It's for women as well, and it can have just as of an impact on their life as it can on the guys.
Yeah, absolutely. I mean, we've had lots of female patients, contact us back of just how much better their lifestyle is and their relationship was with their spouse or husband, boyfriend, just by coming onto therapy. I mean, it makes a huge difference in both their lives. And as kind of we've touched before, you get a male and a female couple together on it. I mean, they're rock stars. I mean, they both feel just so much better in life and how they coexist together, but then also in their jobs, their family, their friends, things like that.
Yeah. So we've talked about it's for men, it's for women. We talked about testosterone and estrogen. What age range does this fall in? How, from the youngest to the oldest, where do you see this therapy being implemented?
So the majority of your patients are going to be in that 35 to 60-year-old range. However, we'll see them as low as 20 and up in their 70s. So it all just depends on what their need is. If I've got, young patients in their 20s, cops, military, first responders, people that just still want to hit the gym very hard at that age, they're the typical clients that we see. We'll see the executives, the retirees that are in their 60s and 70s that are coming in with symptoms as well, because obviously they've got an age-related type of issue of underproduction of testosterone. So,
especially with the younger guys, I know one of the questions on the HRT questionnaire is about having children down the road. And so you have some guys that come in and they're 20 years old and their testosterone's 300, whereas the average 20-year-old's probably 700 naturally?
Correct.
Something
I
like
would
that?
hope they're that high.
Yeah,
for sure.
So in that situation, you treat them a little different. You don't just put them on testosterone because testosterone does reduce sperm count.
Correct.
Granted, it's reversible to a degree because I've personally dealt with that. I've come off, got my sperm count up, became fertile, and then got back on therapy. But what would you do in a situation where a guy's 20 years old, he has his total testosterone is 300, he's, considers himself an athlete, or he's a police officer, but they still want to have kids. What would you do in that situation?
So in that situation, I would basically want to have a little bit further discussion with them of how serious they are about having kids and how soon. Because if they're in a situation, I'd like to have kids, but they don't have that person that they know they're going to have. Like, they're not married. They don't have the long-term girlfriend that they think they're going to have a kid in the immediate future. Then I still think testosterone's, certainly a great option for them right out the gate. If they're in a situation where they're already planning for kids, then we tell them, okay, here's the issues, as you mentioned, with testosterone. It's going to lower sperm count, which could make, fertility a little bit more difficult for them. Mm-hmm. Outside of that, we've got a couple other options that we use between Clomid or HCG, which can boost natural testosterone levels and testosterone production from the testes to enhance their levels. And those are both safe type of medications that you can be on if you're still child planning at that age.
Okay.
So that would be our first discussion with them. Dietary habits as well. We look at those types of situations and see if we can improve that.
So just judging off of what I've seen you do in the past several months, is your go-to initially is going to be Clomid, right? Mm-hmm. And that's an oral.
Yes, oral tablet.
And then if that's not sufficient, then you'll go to HCG?
Yes.
Why is that?
Because it stacks on itself, so I think that you can aid the natural production. That you want to start with basically in my opinion, the easiest to take, the less cost for the patient, which is going to be Clomid. When you add HCG on there, it's It's more expensive by far than the Clomid, and it's still injectable. It's something that you got to keep chilled, in the refrigerator too. So you got to monitor it a little bit closer. So I think there's a little bit more expertise when you get to that from the patient side, prescribing the HCG. However, I think it's just a good alternative that if you're just not seeing a natural bump with the Clomid, then you can do that as a secondary option.
Okay. And we're seeing some guys request HCG with their TRT, and that's mainly just to combat testicular atrophy, right?
It is, because I've seen less issues with that, but I also think it's another way that you may be able to decline the actual testosterone dose by adding the HCG to it as well.
Okay. From 35 on average, you're losing anywhere from like 2 to 5% of natural testosterone production every year.
Yeah, that kind of holds true. The way the hormone system works in a male and a female, and when you look at males, basically mid-30s, you're going to start to see a decline. Okay, in females, right around 32 to 35, they will start to change basically their hormonal levels, where you'll see decreased bone mass. They will gradually lose that. You'll start to see gradual decline in the overall hormones, and that obviously then can take 10, 15, 20 years to get into menopausal states. So it's the 30s that we all loved way back then, but yet, what's going on inside our bodies, that's where the changes is actually occurring.
Okay. Yeah, we didn't talk about too much of the effects of having low testosterone. You talked about like loss of bone density. So there's a lot of downside to, it's like we were saying, you don't want too much estrogen or too little. You don't want too much testosterone or too little. In this situation, there's definitely a downside to not being optimized or having your hormones in check, because you lose bone density, you put on more body fat, you'll lose muscle mass, just your overall well-being, and I guess maybe not, you're not going to shorten your life, but your durability and your quality of life will be adjusted, right? If you're low T, especially if you're real low.
Yeah, your quality of life will be completely different, as far as your sleep patterns will be off, which is going to then affect you the next day as far as being able to function. Mental, cloudiness that people talk about, it's real. I mean, I had to come off of testosterone for about 4.5 months just to kind of get some medical evaluations done for something that had nothing to do with testosterone that I was on. And during that process, I couldn't hit the gym. I was off the medication. I told my girlfriend, I said, I swear I'm like 80 years old. I can't remember anything I just did 5 minutes ago. And I felt like I was asking redundant questions, over and over. And then once I finally got through the process to make sure everything was, good with me, I got back on it. And like a month later, I'm rocking back in the gym and things like that. And now at 54, I feel stronger now at 54 than I did in my 20s and 30s. I mean, my bench numbers have come up. Everything that I do in the gym now, it feels like it's just way stronger. And I'm always having, some challenges with some of the high school kids. Like, let's have a little lift off here.
Right on. Well, and that's something that a lot of people are talking about, is the physical performance. You can see the physical change. But what you were mentioning was the brain fog and the clarity. Yeah. I think there's a lot of the mental aspect of having hormonal imbalance that people aren't talking about. I think it gets misdiagnosed. Obviously I'm not a medical doctor, but I help do the process as a liaison between just showing the new clients the process, what to expect. And a lot of guys are coming to me recently and they're saying, yeah, my doctor diagnosed me with depression, wants to put me on SSRIs. And these guys, some of them, they've been on it for years. And if I understand it right, SSRIs are not designed to be on for year after year after year. It's supposed to be a short-term thing. And so it turned out that they were just low T. Yeah. So it's interesting that, because it's easy to see the physical side of things, and everybody loves that recovery, the extra strength in the gym, but the mental side is critical, is just as important. So I guess for the guys that are looking at this and the girls that think, well, I don't even work out, like this wouldn't be for me. It's not, right. You yourself have seen a lot of mental
absolutely
benefits.
So I think that from a mental clarity standpoint, it's not that it makes you smarter. It just makes you more efficient, and kind of the fatigue that you can get, say, mid-afternoon, that's gone. You'll start to just feel more awake and energetic throughout the day and things like that. Your thought processes of running from one subject to another are more clear in how you process information. And for me as a surgeon, it was never that I couldn't function. Obviously, I had to and things like that. But when my sleep patterns improved, that then made my daily process of dealing with patients in the office much easier, much more efficient and quick. So I think the patients that they talk about this so-called fog. It's more just a mental fatigue than it is anything else. And once the processes clear up, people, as you mentioned, that may have been just thrown pills at because their doc thinks they're depressed. They don't need those pills. They just need hormone balance more than anything else. I mean, hormone balance is probably one of the most underdiagnosed conditions that we can ever imagine in medicine right now.
Yeah. Well, and so I have some other doctor friends, and I asked them, I said, well, how much time did you guys spend on hormones in school? And it's like, hardly any.
I mean, that's way back there, but I don't remember having any discussions besides this is what progesterone does, this is what estrogen does, this is what testosterone does, not the full balance of, how do you optimize therapy and treat people like we do now.
Right.
And part of that's just a change in society, that more data has come out. Our lifestyles have changed, even from 20 years ago when I was a resident, that there's so much more going on social media. There's so much more going on television and computers. I mean, we're attached to some type of electronic device. And as I always tell, the kids, like, get your butt out of the house and go outside and do something. Ride your bike, go for a walk, anything. Just get off electronic devices. And our brains now have been so tuned to 6-second blips on any type of electronic device that it kind of has changed just the mental thought process in a lot of patients. And that's where I think, mental disorders, depression, a lot of the things that are out there is a change in society, but it's also because of hormonal imbalance as well.
Yeah, and I was reading a study the other day, and testosterone levels are lower now than they ever have been. Mm-hmm. And I think it's probably related to some of that stuff, the technology, and it's also the food, I think. Yeah, it's got to be
processed.
Right.
Yeah. So I think that, people that focus on more natural, organic diets certainly do better. I mean, we've had discussions as far as, what we eat and things like that. So in my own practice, there's been studies that have come out over the past few years that talk about testosterone levels and bone mass in total joint replacement patients. So I do a fair number of knee replacements, some shoulder replacements. I don't do many hips. I don't really like hips. But if you have low testosterone and you have demineralized or basically low vitamin D content in bone, that will not allow the implants to be as solid and stable long term. So they've had lots of problems with those implants that we put in, either failing, loosening, things like that. Now, luckily, I've not had any of these, which I'm very thankful about, but I want to at least keep up with the studies are, and that's why I've had more discussions with my patients now that are undergoing joint replacement to, hey, let's look at this other thing. And they ask you, why are we checking my testosterone? And you have to give them the spiel about that.
Come on. Colin, last week, I think, he was getting testosterone through the VA, which, the military has really relaxed on testosterone. They're more supportive of it now, where I think before it had the stigma. This gentleman, they prescribed the VA, and I think they're kind of overwhelmed as it is because they have so much going on, but they prescribed him 100 milligrams every 3 weeks. And, in my opinion, that's worse than being low testosterone. You're better off not taking anything, because say if it's cypionate, you take 100 milligrams your first week for 7 days, you'll probably feel pretty good. And then for the next 14 days, you feel like garbage. Yeah. So, and I just think it's circling back to, they just don't have quite the knowledge on hormone therapy. They're willing to consider it now, but even still, they don't have all the knowledge and know exactly, well, we're going to make him feel worse because he's going to dip. Whereas if we do this once a week, he's going to stay more consistent. And then occasionally you'll have a client microdose, right? I do. And tell us a little bit about why we do that.
So microdosing is done for patients that we start them out on a single dose a week, and that's basically done, every 7 days. So say they get to day 3.5 or 4, and they start to feel like they're getting some symptoms, and it's just not quite there. We're basically seeing that the absorption rate that they have in their body is higher than some other patients. So they kind of hit that peak for the first 3.5, 4 days, and they start to valley out at that point. So that would be one reason then to split their dose in half and do it twice a week. The other option is if we see people that have elevated blood counts, and again, there's theories both sides of this model, that if you see increased red blood cell counts, which causes increase in your overall red cells in your body, then you either have to blood dump or you have to microdose. And we've had good results in patients that start to see that retic count go up or the red blood cell count go up to microdose them. So the expansion of the red cells is not quite as quick to occur, and the body can adjust to that faster, so that way they would not have to blood dump.
Okay. Yeah, so if I'm understanding that right, if you're on say we're on a 10-day timeline and you're once a week injection, by day 7, you're starting to dip a little bit.
Yes.
And so those individuals might feel a little bit drawn down the last couple of days, then they take the shot and they're back up. So what that does is it keeps it consistent in the bloodstream.
Mm-hmm. Yeah. It'd be like, the example I can give for people is, our workers out there in the workforce that are blue collar, they aches and pains from working in a factory, some type of line job. They'll take an ibuprofen, a couple of them once a day, maybe every 2 or 3 days. Well, they're like, God, I still hurt. Well, you never take that medication as you're supposed to, frequent enough, and the amount to keep it high enough in your bloodstream to make it effective. So that's why you'll get a short-term burst of relief. Well, then it's gone, and you start hurting again.
Right.
Same theory with the testosterone, because of how long it lasts in your body for some people versus others. The standard is once a week, but then you'll still have some people that will split that in half. I've got a few people that we even do it 3 times a week.
Oh, wow.
That they're hypermetabolizers. That's rare, really rare, but the standard would be once or twice a week, though.
Okay. Would they be on Cypionate if you're doing 3 times a week, or would you put them on like a propionate?
No, I would still stay with Cypionate.
Okay.
Yeah.
Interesting. So, guys, the testosterone's not an anabolic steroid. We're not talking steroids here. A lot of these guys, they're almost ashamed if they have low testosterone. But if you were deficient in vitamin D, you'd have no problem taking a vitamin D pill. You know what I mean? So the stigma's got to get dropped. Like, there is a lot to be lost by being low T, not just from a physical point of view, but also from a mental point of view. So at a minimum, get your blood work done, figure out where you're deficient, and then guys like Dr. Main can tell you how to get everything right. I did want to talk quickly about medical weight loss and then maybe a little bit about the peptides. But medical weight loss, who's the perfect candidate for it, and which ones are the best? Because there's a few out there, in your opinion.
Well, I wish I could get the I guess what we call it, the signing bonus from any of those companies that need to promote them there. So we look at anybody that comes in that they think they're overweight. Okay, they don't feel good. They're not the body type that they used to be or want to be. Again, same rationale. We're getting blood work ahead, which the medical workups for the weight loss is a little bit more in depth. We're adding a couple other blood tests to that. We look at their height, their weight. We'll calculate their body mass index, which some places will do that in addition to looking at even bone density, because that's also a marker that we look at and determine where they're at on the BMI scale. So theoretically, anybody that's 27 and above can be treated. Okay, if you look at the government regulations on that, from if you're getting it through insurance care, I've got a lot of people that'll be still down in the 25 range. When you look at their BMI, you look at them like they still don't look lean at 25 because they're too short and too wide type of thing.
Okay.
So it just doesn't match up. So the majority of people are going to be 27 BMI and above, which we can see them up in the 40s and 50s, that they're just super obese, morbid obesity, that we want them to lose some weight. We have to clear them to make sure that they don't have any history of thyroid issues or thyroid cancers. That is a black box warning. If they have, identified thyroid issues, it's not a recommended medication to utilize. My experience in the past is you've had all the name brands between, Majerno, Wegovy. We use a lot of semaglutide at this point.
Yeah, it's like Ozempic,
yeah.
Trizipatide. That's kind of the trending one right now, right?
Yeah, that's the new one that's out there. So each one of them has got, a slightly different formulary as a GLP-1 type of medication of how it affects insulin resistance and production in the body, basically, and causes some appetite suppression and kind of a catabolic effect that actually helps you lose weight. Everybody's a little bit different as far as how they respond to that. And you may have the same patient go through 2 or 3 of those types of medication that they either have some side effects or they just don't feel like they lose anything, and then they finally get on another one and boom, that's the one that works for them.
Okay.
And I think it's because if you look at the compounds that these things are made of, everything has got kind of a base compound like a generic, but then there's little added features that each company's got to put onto it that makes it their name brand.
Sure.
So for the most part, we use a lot of compounded type of formularies for that. There's still some name brands that we utilize. And it's a tiered system where people are getting injections based on how many units each week that we kind of progress them over a series of really months with that to try and hit their target weight. If they start developing these symptoms, we can back that dose back down, see if we can get rid of some of those symptoms. Sometimes with these, we'll actually change where they do the injection because there's been more research come out that most people are injecting in abdominal fat subcutaneously. Well, there's more studies that show that people are having more of the GI symptoms by injecting there versus in the thigh or even underarm area as well. So I think that's another thing that they're looking at now is to try and identify, is there a better alternative based on each type of medication that might be more functional?
And sometimes, so it's not, as opposed to testosterone therapy, this isn't something that you're on for years, right? No. And then, so you'll have a client on medical weight loss, Ozempic, tirzepatide, whatever, and you'll taper them. Once they get to a certain manageable weight, you'll taper them and they'll put them on an oral. Is that correct?
We have that option, yes, to go to an oral. So there's companies out there that we work with that have a sublingual tablet, that's just a dissolvable tablet you put in your mouth that can be utilized basically, as long as you want. I do think that there needs to be time periods that people come off of that because, again, the drug alone itself helps you, but you still got to do your part as a patient, still walk, still have dietary control, eat the right foods, still have, some type of, aerobic or anaerobic exercise workouts.
I've had multiple family members get on medical weight loss, I believe Ozempic, and they've had completely different results.
Yeah.
And they've all lost weight, but whereas one's kept eating, kept good nutrition, even if they weren't hungry, they kept eating because that's what these do. They slow your digestion, right, and they make you less hungry. And then they would keep on the nutrition and they would keep resistance training. And then on the flip side, my other relative just said, I wasn't hungry, I stopped eating, and I barely worked out before, and I just quit working out. Well, that individual lost fat and muscle.
Bone and muscle.
And, yeah, right? So honestly, in my opinion, at their age, they would have been better off having a little belly and being holding more muscle and having more bone density rather than dropping 20 pounds.
Absolutely. And I'm glad you pointed that out because that's where we talk about some of the bone density studies being involved in this, or at least, body scans that we can use to look at muscle mass and bone mass as well. Because there's been a lot of complaints about, as you mentioned, people that take the drug, they lose weight, but they don't work out, and then suddenly their bone density is different. Well, you have to do that resistance training in order to maintain your bone mass and muscle mass as well. Otherwise, you theoretically are going to lose more weight from the things that you don't want to in addition to the fat.
Yeah. I think what a lot of people don't understand, and this is true with hormone therapy and medical weight loss and peptides for that matter, this isn't a magic bullet. There still requires work. It's it's supplemental to a good diet and being physically active. Yeah. And we're not to a point where we can, maybe the government can modify DNA and just get that result. But I think people need to understand that it comes with some responsibilities, and it comes, if you want to get the full result, you can't just take it and let it ride. You need to be eating a balanced diet. Even when you're not hungry, you need to be staying physically active. Otherwise, you're just going to deteriorate.
Yeah, absolutely. That's why the patients have got to do their part and take their own responsibility in this treatment program. We can make the recommendations, we can lead them in the right direction, but ultimately, it's up to them.
Right. Well, I don't want to keep you a whole lot longer, but I wanted to touch a little bit on peptides. Myself personally, I come from a bodybuilding background. The guy I train with is 320 pounds, and he's like 15% body fat strong as an ox. So I still train hard. But the only way I'm really able to recover was BPC 157. So that's my favorite peptide. There's a bunch of peptides out there. BPC 157, hands down for me, it comes right after testosterone. I joke with my friends. I say, give me testosterone, BP 157, and Jesus, and I'm good. But there's a BPC 157, I think maybe the CJC 1295. There's a handful of these peptides that were probably the best, in my opinion, that the FDA recently has shelved. Yes. Tell me a little bit about that.
So I think part of that had to do with just overall regulations of the pharmacies. So because hormone therapy has started to pop up and become very in vogue in culture, we were having pharmacies be developed that weren't really being monitored and were producing products that the results of what they were putting out on the market was so variable, it came into a safety concern. And I do know that there are pharmacies still open that are much more FDA regulated. A lot of those are physician owned or managed, so that way they're held to higher standards than just a mom and pop shop trying to produce this stuff. So I do think that some changes obviously have occurred and will continue to occur, but I don't think that these are going to be completely taken off the market long term as pharmacies, groups like ours continue to work with the individuals that are involved in some of this regulation. So I do think that there are other alternatives out there, but yeah, I'm like you. I've had a lot of people on BPC 157 for a while, and they swear by it after the recovery periods just to make them feel better. And I do think that there are some other options out there, but it's just trying to identify as new things hit the market, what those are going to be. I mean, there's 1,000 peptides on the market right now.
Right.
I can't keep up with 1,000 peptides. Sure. We go with our go-tos, and every few months we'll have somebody say, "Hey, look at this one. It's a new one that hit the market."
Right.
Kind of thing.
Yeah. What people need to understand is these are just amino chains.
Yes.
It's not some of this stuff you're getting in your food.
Yes.
It's we're not talking about some radical compounds.
It's not steroids.
It's definitely not a steroid. A lot of people compare it though. Do you remember SARMs that came out a few years ago? I mean, in my opinion, SARMs are absolute garbage. Being a bodybuilder, I was competing at that time. I tried a few because our local supplement store sold them. Yeah. Just gave me headaches. But we've had some guys that have gotten blood work, and they say it completely shut down their natural testosterone production. So I don't want people to get confused with SARMs and peptides because they're completely different. Right. I'm not a fan of SARMs. I don't know if you've ever dabbled, but
I have not.
For every person that says that they've maybe had good effects with it, it's hard to tell because they were doing other stuff. Yeah. And a lot of that's placebo, But for me personally, I've tried it twice, and both times I'm like, God, I just got migraines. It doesn't do anything for me. So, TRT and peptides are excellent for guys like us, women as well, that are just trying to stay in shape, stay healthy, or have an athletic edge, right?
Oh, yeah.
So that's really what I wanted to go over with you today. I think you and I are in the same opinion. We could talk about this all day long.
Yeah.
But, I just wanted to clear the air on a few things, especially TRT. Like, it's not something to be ashamed of.
That's the biggest thing. I mean, that's one of the reasons why I think telemedicine is becoming so popular is people don't want to go in and have that face-to-face conversation with their doc when they know that person. It's someone they see on a regular basis potentially. Versus telemedicine, you're going to see one of our providers and you'll see them again at a follow-up, but that's it.
Sure.
They're not going to be around the corner in your next kid's baseball game or something like that. and some of the discussions coming in, with the relationship type of issues and sexual dysfunction, they're afraid to talk about it.
Right.
Versus we're here to help.
Right.
Plenty of clients, their relationships and marriages have been saved by getting on therapy like this. I mean, we talked to Andy, that was one of the first things he told us was his life is completely different with his wife now that he started on this.
Sure. Yeah, I mean, I know just to piggyback off that point, there's a lot of couples that have just kind of grown apart. And, I was off of testosterone when I was married. I was off for 8 months, and I definitely noticed a difference. Mm-hmm. And it's not that you don't love your spouse still.
Right.
It's just the desire to pursue them isn't there, but they don't know that. Right. Unless they are in the know on hormone therapy like we are, they're not going to know that. They're going to take it as, well, he's just not giving me the attention he used to. It's not like it used to be. And then that can dissolve a relationship.
He doesn't like me anymore. Who else is he with? Type
yeah.
of thing. It creates communication completely breaks down, which then from there resentment comes into play, and just all host of spiraling down negative effects start to occur. And then I think if they can sit down and just have that frank discussion of, hey, this is how I feel, what's going on in my life, type of situation, I think I may have found some treatment options for me. Let's go check this out. Yeah. And lately I've done a couple consults that have been husband wife couples that they both want to be on the therapy. Yeah. And that's pretty cool. I like that.
I talked to two people yesterday, or actually two of the husbands, and they both sent me their wife's info. Said, hey, let's get her blood work done too, because now she's interested. She sees the impact it's made on my life. Yeah. So they're like, well, what if we could both be operating on a little higher level, and be healthier?
That's a power couple, I tell you about.
Yeah, it's cool. It's really cool. It's not just for guys; it's for men and women. And testosterone, or having the proper hormones in general, is going to affect so many different parts of your life that we're just hitting on a few things, but I mean, from physical performance to business to relationships. That's not just with your significant other, but your kids, you know.
Yeah.
Some of these guys like, dude, I work all day. I'm gassed by the time I get home. And then I see my kids and I want to play with them, but I just don't have the energy. And now they're like, I can get up and play. You know what I mean? So there's a lot of different areas in your life where it can benefit. And I don't even know that I'm aware of all of them, because everybody has different elements of their life. But I really think that it's having low testosterone for men and women, or being hormonally insufficient, is going to be such a downfall. And it doesn't have to be that way. You don't have to accept life as, I guess this is how it is. I'm just getting fat. I don't have any muscle and no energy. Yeah. Like, that doesn't have to be like that. And I think guys are finally getting the awareness, like, hey, I have an outlet to this. And, you know, for me, the coolest part of this whole business is these follow-ups. Yeah. Talking to these guys in, like, I don't know, 5-6 weeks down the road, 3-month checkups. They're like, they're your number one fan. Yeah. Because there's very few things in life that you can give to somebody or help them with that's going to have this much of an impact. Mm-hmm. So it's a huge blessing, in my opinion. I feel like we have a duty to make sure that people are living up to their potential and having a high quality life. And it's a fulfilling job to have, for sure.
I went into medicine years ago because, number one, I grew up in a family with a construction background. So as I tell my dad, I turned from building houses and reconstructing things in houses and things that you do to, you know, do that type of work, to now rebuilding people. And out of all the specialties in medicine that I looked at, I knew I wanted to get in something I could make an immediate impact in people's lives, and orthopedics has done that for me. That they tear their ACL, I can reconstruct that. They tear the rotator cuff, I can fix that. Mm-hmm. It's kind of the same with hormone therapy, that they have deficiencies, and all you got to do is put them on the right medication, and their life has changed. You know, they've got something now to look forward to every day.
Yeah, I don't know really of anything else other than, like I said, Jesus and your faith. They can have that kind of a change and impact in your life. So
I can say that's one thing I really like about you, Matt, because I see the barbells and Bibles type of thing here at the gym, and man, that's awesome. I really respect that, and I think that's something great that you're doing for a lot of individuals.
Right on. I appreciate it. We have 3 Bible studies now going. I don't host any of them. I used to host them. Mm-hmm. So I kind of get them started and then hand them off. The one in Manhattan is ran by my buddy Barry Park. He's our pastor in Manhattan. He was on the podcast. That'll be dropping probably next month. Mm-hmm. He runs that one. Tay Jones is a trainer. He runs one in Liberty. Yeah. And then we have a young pastor here that runs the one here in Olathe Shade, and they're all doing a great job with it. It's really neat because there's a lot of people that are they're interested, they have questions, they're wanting to pursue their faith, but they're not ready to step into the church. Yeah. But they're already in the gym, they feel comfortable with this environment, these people. Mm-hmm. And so they're like, oh, you know what, I can go sit into a group and let people talk and hear it, and it's a lot less intimidating. And I think they look at guys like myself, like you, they say, well, that guy's successful, what's he doing? And then they see, like, oh, well, faith is a big part of our life. Mm-hmm. They say, well, maybe I'll consider that as well, because I've always had questions. I just hadn't had anybody, lead me there. So that's another thing I think is kind of a duty. Yeah.
We're making impacts on people's lives, no matter if it's from the medical side or just the personal side. And that's what I love about this business.
Right on. Yeah, there's a lot of ways, a lot of businesses you can be in. You can make a lot of money. If we were during COVID, if we were in a liquor store, we would have been millionaires. However, just because it makes money doesn't mean that you're right helping people, right? So that's something between our faith and with the business, the hormone therapy, we definitely can feel good about what we're doing because we're helping people manage their lives, especially with their hormones, and live to their full potential, but doing it in a safe way. Yep. So, yeah, I appreciate that. One other thing I was going to get on, and I don't think we will today, but you were talking about like hip replacements and knee surgery and stuff like that. Mm-hmm. I have a friend who recently tore both his quad tendons. They're going to put in a cadaver tendon, and you and I were talking about stem cells. Yeah. And what a lot of people may not know about Dr. Main is that he is one of the top stem cell doctors in the Midwest, right? You used to be flown around by the military to their bases to do stem cell therapy on their soldiers, correct?
We did. During COVID, a lot of the military hospitals shut down except for just straight emergencies. So they had contacted certain individuals to contract with the military that had extreme experience in stem cell therapy, which I've done probably 25,000 stem cell injections over the years, that they wanted us to come in and basically treat active duty and retirees in a way that would accelerate recovery programs and healing. And we did that for several military institutions around the Midwest. Actually was able to publish some reportable data on that from some type of injections that we did with that, and saw the wonderful benefits of it, and kept guys out of the operating room to get them back on their duty activities and requirements, to service and take care of us here in the United States.
Yeah, that's awesome. I think stem cells is something I find fascinating. It, like you said, accelerates the healing process. That's something that we're wanting to bring on to Prime, and that's why Dr. Main's such an asset, because he has so much knowledge on this, is one of the experts on it. So maybe that's something that we revisit as we get down the road. We got we're taking Prime across the nation right now, with your compact license that opened up to 38 states. The goal is to be in all 50.
Yep.
So we got a lot of work ahead of us, but I definitely plan on adding stem cell therapy to that model. However, that's going to require a physical location rather than telemedicine. So that might be a conversation we have another day.
I'd love to sit down and talk about it.
Sounds good, man. Chris, thank you for coming on, brother.
Thank you. The official Dr. Main, if you could look me up.
Oh, yeah.